So next speaker is Mr. Manoj Parulekar, consultant ophthalmologist, Birmingham Children's Hospital, UK. So Manoj is a great teacher, great clinician, and he was instrumental in training me and Hasanka as well. Yeah, Manoj, over to you.
Can everyone hear me?
Yes, Manoj. Yeah.
Excellent. Well, Hiranya, Hasanka, lovely to see you all. Thank you to the President, Amila, and to all of you for the very kind invitation. I have very happy memories of every visit to Sri Lanka, and I look forward to being there in person again. But until then, hopefully this will suffice. My first presentation is about acute. Would you like me to do the two back to back? Would that be easier?
Yes, please, Manoj, if that's okay with you.
Yeah, sure. So the first presentation is about acute onset esotropia. Should we scan them all? Now, we know that when we have a child presenting with acute onset esotropia, they can present at varying ages. It could be an infant, it could be a young child, 2 or 3 years old, or indeed it could be a teenager. I'm going to restrict myself to children. I'm not going to talk about adults. And the real question is, should we scan them all? Well, the truth is most of them don't need a scan, but some do. How do we identify those, and how do we avoid scanning the others? And the real worry, both for the parents as well as for us, is I'm just going to try and put my laser pointer on, is the presence of a brain tumor. That's the most terrifying thought for both the parents as well as the clinician. All good examinations start with a good history. So the question is the squint intermittent? And that's a really important question, because if you have a paralytic strabismus, then you would not expect the squint to be intermittent. If it's intermittent, it usually means it's an accommodative refractive squint, and you can relax a little bit. So if the parents don't understand what intermittent is, sometimes I have to ask them, are the eyes straight at times? Send me photos. Ask them if it's worse when the child is tired, or is it worse when they look at a close-up object. If it's worse when the child is tired, then that means there's a variability through the day, and that means there is a degree of control in the mornings, which is typical for most forms of refractive strabismus. Or when they look at a close-up object, it might indicate that accommodation is coming into play, and again, that's more indicative of an accommodative refractive squint. Now, this child presented with an intermittent squint because that's her in one of the pictures, and you can see in yet another picture, her eyes are straight. And for us, that's hugely reassuring. And so this one does not require a scan. There are some red flags in the ocular history. So I ask questions like, is it worse in one direction than the other? Is it consistently one eye that turns? Now, if it's worse in one direction than the other, that indicates it's an incomitant squint. And incomitant squints, one of the forms of incomitant squints is paralytic squints. And so you need to be mindful of that possibility. Is it consistently one eye that turns? That doesn't really necessarily distinguish between a paralytic or a sixth nerve palsy and an accommodative convergent squint, because accommodative convergent squints can also consistently have one eye that turns in. But if the child turns their face to one side to try and control the squint, then that again indicates that there is a degree of incompetency. And then, of course, you ask about any double vision, because in the slightly older child, or indeed even with the younger child, before they develop any suppression mechanism, if they get double vision, that indicates that this is an acute onset squint. So it doesn't necessarily tell you the cause, but it just tells you that it's a relatively recent onset squint. And then, of course, there's a general history. So you ask for a history of trauma, typically head trauma, ask if the child is unwell, ask for and look for unsteady gait, ask for vomiting, slurred speech, or any limb weakness. And all of these are big red flag signs. And if those are present, then the child requires a scan. Now, on the examination, there are quite a few things that I look at, and I'll quickly run through them. Abnormal head position, limited eye movements. I check the saccades. I refract. Every child needs a retinoscopy. A careful fundus examination, check the binocular vision, and look for associated features such as ptosis. So this is a child who presents with a sudden onset convergent squint with an abduction deficit. What do I look for next? I look for an abnormal head position. This is a girl, a teenager who presented with an abnormal head position. It was a very subtle abnormal head position. And what was very interesting was that she had a moderate abduction deficit on that right side. Now, this could well be something like a long-standing Duane syndrome. So I asked the parents to send me pictures from the past. And they sent me pictures, and that will become apparent later in the presentation. This is another boy who presented with an abnormal head position, and he was adopting a more marked head position. So clearly, this is an concomitant squint. Now, about that girl, when we asked for photos, parents sent me photographs which showed the right eye abducting freely and fully. So clearly, this was a new onset, what appeared to be a sixth nerve palsy. And indeed, this child turned out to have a large brain tumor and unfortunately succumbed to it. I carefully examine the child with occlusion. Now, with occlusion, I always check if the abnormal head position disappears on covering one eye. If that happens, if the abnormal head position disappears, it indicates that the child was adopting the abnormal head position to control the diplopia or for some binocular advantage. And if it's a slightly older child, I ask them about whether they are actually seeing double and if the double vision disappears. I check the uniocular range of movement. Now, it can be tricky with a child. So what I often do is I tend to cover one eye. Sometimes you put a patch on one of the eyes, send them out into the waiting room, and ask parents to observe their eye movements and take photographs, and then call them back into the clinic. And this child who has a rather large convergent squint, you can see, you can get the child to abduct quite nicely with a degree of occlusion of the right eye. I checked saccadic velocity, and I could not get a video in a child. So I'm going to show you an adult patient. And you will see, if you observe the movements looking to the left, you can see that the abducting saccade on the left is much slower than the right. It's almost like it floats into position. Watch again and keep watching. And this is very, very useful because this indicates that there is a degree of weakness of the left lateral rectus. And that indicates a cranial nerve palsy. Now, 6 cranial nerve palsies can be unilateral or bilateral. They can present with acute onset esotropia, with limited abduction, with face turn, and reduced saccadic velocity. So if all of these things add up, think of a 6 cranial nerve palsy, and this child should have a scan. Now, the other thing I look for, which is very useful, is inferior oblique overaction. So this girl presented with right convergent squint. And if you look carefully, the right eye is also slightly elevated. And if you look at the eye movements, you'll see that the right eye elevates in adduction. So there is an inferior oblique overaction, which you will not see with a sixth nerve palsy. Now, you could argue that you could see it with a fourth nerve palsy. So if the child has a sixth nerve palsy and a fourth nerve palsy, then of course you could get superior oblique underaction and inferior oblique overaction. But do remember that the sixth nerve is present further down in the pons, whereas the fourth nerve nucleus is present in the midbrain. So it would be unusual to have such a large lesion that affects your fourth and sixth nerve without affecting your intervening structures and giving you some sort of other neurological deficit. Also, along the course of the fourth and sixth nerve, usually the fourth and sixth nerve have the third nerve very close to each other. So it's not very usual for the fourth and sixth to be involved without other nerves being involved. So if you see inferior oblique overaction, it's a pretty reassuring sign. This is another example of a girl with an inferior oblique overaction with an acute onset convergent squint. And again, this was a very reassuring finding, and this child, of course, had an intermittent squint. Now, the other thing I look at is the physiological V pattern. So if you have a sixth nerve palsy, if you've got acute convergent squint from a sixth nerve palsy, the eyes are not going to straighten in upgaze. Whereas a typical garden variety childhood squint, if they have a V pattern, and most children do, the minute they start to look up, they will find that their squint starts getting better. And so using the physiological V pattern is another clinical filter that you can apply to rule out anything nasty going on. And of course, you have to refract these children. And if you put them into glasses and their eyes straighten out, then that's a very useful, reassuring finding. But of course, until they return to the clinic with their glasses, you're not going to know. And often the decision about whether to scan or not has to be made in clinic. So glasses are something which give you a bit of a retrospective confirmation. This boy presented with an right face turn, as you can see. And when he looks straight ahead, you can see his right eye does not abduct. Now, this could be a right sixth nerve palsy. But what you've got to also look at is the fact that he's got a downshoot in adduction. And this was a case of Duane retraction syndrome. So this is another girl who presented with a limitation of abduction of her left eye, and parents noticed the squint, and they noticed an intermittent squint. They said it's present in certain positions of gaze and not others, which could, of course, happen with a sixth nerve palsy. But when you look at the full picture, you can see she's got a narrow palpebral fissure on the left compared to the right in primary position. And when she abducts, there is no abduction on the left. When she adducts that left eye, you see there's narrowing of the palpebral fissure. So that is retraction. And this globe retraction indicates that this is a Duane retraction syndrome. This is a girl who in primary position had a left convergent squint, in left gaze had no abduction of that left eye, and in right gaze, her eyes were quite well aligned. She had a slight narrowing of the palpebral fissure on the left. But then, of course, if you look at the full face, you will see that she's got a degree of asymmetry of the smile, suggestive of Mebius syndrome. This girl went for surgery, and she had a late onset acquired esotropia, which is very commonly seen in slightly older children. They've been holding things together because of their fusion mechanism, and then at some point it decompensates. Now, when you see someone with unilateral sixth nerve palsy, or indeed anyone with an acute onset squint, don't forget to examine the fundus. They might have either papilledema or optic atrophy, and that will further guide your management. You can get sixth nerve palsies with idiopathic intracranial hypertension, where you get sometimes bilateral sixth nerve palsies, and it is one of the famous false localizing signs with raised intracranial pressure, where the sixth nerve passes over the apex of the petrous temporal bone. Always consider myasthenia when you've got variable signs and symptoms, or if there is associated ptosis. So this girl had limited abduction, and she presented another day with myasthenia, with bilateral ptosis and limited elevation, and turned out to have myasthenia. So just to summarize, the red flag signs, if you see any pupillary abnormalities, ptosis, proptosis, poor vision, associated features, abnormal red reflex, and of course, you take the examination in that direction. If you see abnormal eye movements, limited eye movements, gait disturbance, or other neurological signs, then it takes you down a very different path. I'm going to stop there.